Welcome to COVID-19 Bolus, recording live from Canvas Studio. My name is Alan Dow, a general internist from VCU Health System. Today is June 1st at 3 o'clock Eastern Daylight Time. As a disclaimer, COVID is a rapidly evolving pandemic. While we strive to be current, information may become quickly outdated. This information is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Individuals with healthcare questions should contact a healthcare practitioner. If you have a medical emergency, you should immediately call 911. This session is supported by an independent medical education grant from Pfizer. Thanks to them. Our guest today, Param Jabari, is the Chief Deputy Commissioner at VDH. He's a physician in public health. Welcome, Param.
Thank you, sir. Thank you for having me.
Oh, it's great to see you. So we're talking today about sort of preparedness and coordination in the setting of COVID and sort of just broadly for the state. So I wonder if you could sort of tell us, how is the state organized to respond to COVID-19?
Sure. The Virginia Department of Health has a department called the Office of Emergency Preparedness. We prepare for all types of emergencies, all types of hazards. We certainly, in terms of a pandemic, that's one that requires the collaboration from many other sectors. But our traditional partners are the Virginia Hospitals and Healthcare Association when it comes to healthcare practices. And we're coordinated through the Virginia Department of Emergency Management in providing emergency response, depending on the nature of the response. Is it a hurricane? Is it a tornado? Are we putting up a shelter? Is it potentially a hazardous spill out on the road? It all depends on the actual incident that defines which state agencies come in to help respond. So before COVID-19, as soon as we got some of the initial information out of China about a potential threat here to the US, we had a lot of conversations internally within VDH. We started working with our healthcare coordination partners through the VHHA, started coordinating our communications through the Virginia Department of Emergency Management, and certainly since the public health emergency was declared and the state of emergency was declared, we wound up working in a much more formal and robust way with many other state agencies as well through what we call the Unified Command.
So I would guess you mentioned hurricanes and tornadoes, which I hate to say that they're garden variety emergencies, but in a sense they're much different in length and impact of the COVID-19 pandemic. So has your unit ever faced anything like this before?
Certainly the closest thing that we can think of is the H1N1 pandemic back in 2009 that went on to 2010 in terms of the public health response with regards to what we were able to do with vaccination clinics. A couple of key obvious differences that your viewers likely know is that when we had H1N1, we had some pharmaceutical interventions, Tamiflu, Relenza, other sorts of antivirals that we're able to use. And in fact, if I recall correctly, a lot of practitioners used to hesitate prescribing those types of medications. And with H1N1, we really brought out the importance of being able to diagnose early and to provide that early treatment. Many of the other same measures still hold with regards to social distancing. But as everyone recalls, the rate of spread was nowhere near as such as COVID-19. The mortality rate was not anywhere compared to what we're seeing today, and the rate of spread. And from an epi standpoint, we saw younger individuals being impacted rather than older. So that's probably another reason why we didn't quite see the mortality rate. So, we got our initial public health responses starting in April of 2009, and until the vaccine was developed and implemented and distributed, it really was a full year-long response. There's nothing really that seems anything close, at least in my mind, to this. We have had areas of the U.S. impacted by various disasters. I was sharing with you before this call started. I trained at Tulane. I was there as a resident when Hurricane Katrina hit. And you can argue certainly the response to that particular disaster went well beyond several months. But a lot of that was also focused on recovery. What makes this disaster a little bit different is that unlike a hurricane, unlike a tornado, we really don't know what the length of this impact is going to be, right? We can't really follow this on a Doppler radar. And we, in fact, cannot really predict if this is going to get worse, if there's a second wave that's going to have a higher peak. Are we going to have certain tools in our arsenal, whether that is medications, whether it's other therapeutics that can help, in fact, mitigate this disaster? So what makes this really, really challenging, I think, is the fact that, again, it's a new virus. So the microbiology, the clinical pathology is going to be a little bit different. We don't exactly know what therapeutics we're going to have. And we really don't know how long it's going to last. So all of these will be elements we'll probably talk about in the next half an hour that makes this response particularly complicated and difficult.
Is there any playbook of how to do this? I mean, I don't even know where you would even look for guidance.
There is that pandemic influenza is one of the threats that we have been studying and looking at well before H1N1 as well. I referenced Hurricane Katrina. The same year, George W. Bush came out with a directive for us to prepare for such threats. And we were really concerned in 2005 with the H5N1 bird flu. We had seen some evidence of transmission. It wasn't quite sustained person to person, but we had seen this highly pathogenic, highly virulent influenza virus in the Middle East being passed on to individuals. So we were concerned. Fortunately, that virus did not get to the level of efficient transmission from person to person that would have made it potentially a pandemic. But a lot of new dollars and funding came towards public health to really start studying and preparing for this. So some of the things that we have been discussing for a long time is, of course, making sure we have a robust strategic national stockpile with PPEs and others. We knew that if we have a pandemic, there may potentially be shortages, not only in that particular effort or venue, but supply logistics chain management would really be disrupted. We knew there would be impacts to businesses. We knew that one of the things we would likely do is close down schools, because while children may not always be impacted the most from the actual illness, we do know that they are really contribute to transmitting the illness within the community. So some of the things that we're seeing playing out in our communities now are things that we have thought about before, have been planning before, and as many of your healthcare providers probably know, have been tested, and whether in exercises, tabletop, full scale, or in real life. I think what makes us particularly unique is that in the public health world, we hadn't really prepared for the economic impact. We had always thought about, and I had certainly in my role in preparing the healthcare community and surge capabilities of how are we going to stand up alternate care sites? How are we going to provide care outside of traditional care, thinking we'll have individuals by the tens and thousands coming in needing care. What really happened the last couple months, and this is absolutely wonderful when you think about curbing the rate of illness spread and certainly deaths, is that we were able to really slow down the spread of this illness by closing down the schools and businesses. But this is probably going to create new challenges, and not probably, in fact, it is, from the economic side. It's going to create real challenges for individuals who may lose their job on their health insurance. And as healthcare providers, we need to think downstream, not only for the immediate impacts of COVID-19, but the secondary health impacts of those with chronic illnesses who may not be able to get the care that they need, those who are in vulnerable communities who may be impacted even further from this particular disaster, and lessons that we learned from Hurricane Katrina or other long-term impacts can probably help guide us through some of those challenges that we're going to be facing in the coming months.
Yeah, it's an interesting parallel to Katrina, parallel and not parallel in that those communities were able to come back stronger. It took a few years, yet at the same time, they were able to bring in surge capacity from outside the area into that region to sort of help. Whereas here, we're all trying to surge together and can't borrow from the next state over or a couple states over.
Right. No, clearly that's one of the biggest hallmarks and challenges of a pandemic, and not only another state, other countries who are going through the same disaster with us, and to a great extent, their ability to recover, whether a neighboring state or neighboring countries, also impacts what we see here. As you say, in certain countries in Asia, they had basically gone back to reopening their businesses, and what they're seeing is a resurgence of cases now, whether that's endemic from their own country or it's from travelers coming in. Here, we in the U.S. have to think about that as well, as we may be able to really get on top of this pandemic and reduce our cases and reduce our numbers, but what about worldwide travel? We may really be able to impact it here in Virginia, but what about the influx of cases through Northern Virginia, the DC border, some of the discussions we've been hearing with our migrant populations and those working in the poultry industry on the Eastern Shore, really a contiguous community all the way up to the Delmarva Peninsula. So the work and what we see here in Virginia is extremely dependent on what's happening in other parts of the U.S., but also, as you said, when we're short on PPEs, we can't necessarily do an EMAC, an emergency medical assistance compact, to get more resources, because everyone else is also struggling with the same challenges.
Yeah, I've thought a lot about that with the heterogeneous approach that states have taken to reopening. That you can close the borders to a country, but you can't close the border to your state if you don't like what your neighbors are doing. Let me ask about this. So, where does your office sit in terms of its interaction with federal agencies? How do those different things fit together?
Sure. So a little bit of a briefer on kind of incident command and how we're organized. So at every locality, at every state, and at the government level, and going back to, again, some of the lessons learned after 9/11 is we adopted the NIMS model. It's a standardized, uniform way of going about incident command. And so the point of this is, regardless of the disaster, we have to be ready to respond. And so when there is a disaster, either on the local level, state level, or on the federal level, we have different cells organized in what's called ESFs, Emergency Support Functions. So Emergency Support Function 1 is transportation, 2 is communications, 3 is public works. And I'm reading off of these because I know 6 is mass care. So when we talk about sheltering, and that's something that is headed by the Department of Social Services and we support. But ESF 8 is public health and medical. So regardless of what the response is, whenever VDH is involved, we are leading the ESF 8 cell. And so in a typical day, in a typical disaster, we are all at the state EOC, the State Emergency Operations Center in Chesterfield. And we're all divided and labeled and marked. We're the transportation, the firefighters, the health. In this case, we're working virtually through all of this. And what we are responsible for at VDH, again, I'm the chief deputy, so help support the commissioner in all of those aspects. Our classic work in this particular response, the operations, is in terms of what we're doing testing, we're doing contact investigation. And my particular part is really doing the coordination with the healthcare systems. And so with some experience from Katrina and going through 4 other hurricanes, both here in Virginia and Louisiana, have a lot of experience with mass surge planning. So one of my first missions was to work with our hospital systems, VCU included, to look at these large regional alternate care facilities. You may have recalled the governor was looking at one at the Dulles Expo, one here at the Richmond Center Convention Center, and one at Hampton Road. So the initial discussions was, how big? What type of patients? Are we going to do COVID positive or non-COVID? And with some of the initial lessons coming out of New York, we were thinking, how is it possible to have a COVID-free environment in a pandemic? So wouldn't it make more sense to make these shelters COVID positive? We learned quickly that a lot of individuals that seek acute care just have a long time, need some time to recover, and they're still spreading the virus. So they've gone beyond the acute recovery phase. They've recovered in terms of coming out of the ICU, but they're still not quite ready to go back home, or they're not quite ready to go back into the long-term care facility. So we did a lot of planning about what types of work needs to be done around those facilities. And that kind of discussion, in my role specifically, was to then coordinate with our hospital systems. Public health can manage and coordinate, but we're not the clinical experts, and we're certainly not the experts in setting up these sorts of alternate care facilities. So our mission, our involvement in a lot of these types of responses is to identify the overarching framework, and then be able to work with partners to actually make it happen. And since then, other things that have come about. So we were able to really, as we saw, again, the disease spread, not necessarily spread as fast as we had initially thought due to the success of our social distancing efforts. Our strategy changed to think about perhaps not having such large-scale facilities and allowing the hospitals through Executive Order 52 that allows them to expand within their campuses beyond their current licensed number of beds, to really look at just high-risk areas. So I've been working with VCU, UVA, and again, a number of other academic partners looking at assisting Department of Corrections. We know that the rate of spread of illness is extremely high in congregate living, congregate facilities. So planning partnership between the Virginia Hospital and Healthcare Association, VDEM, Department of Corrections, and thinking how we do the surge planning for them. Everyone has seen the devastation with the long-term care facilities. So working with our EPI partners to think about how we cohort patients, how we divide patients, and trying to provide the kind of guidance that we can to those groups as well. So the work and response of mine individually has changed throughout the response, again, focusing on the partnership with healthcare partners. Dr. Lillian Peak, our state epidemiologist who's been on your webinar before, is really the key person moving forth our efforts with regards to investigation, disease reporting, the day-to-day discussions with the CDC on what is coming, and then all the other support from Dr. Karen Remley and individuals, again, from Dr. Peek's office with regards to our testing strategy, which was really limited to those who were ill with symptoms in acute care facilities and has gradually expanded to our primary care settings, local health departments, now a new involvement and partnership with federally qualified healthcare centers to be able to get them on to help do some testing, and really moving on with the next phase now to assisting our business partners and those members in the community to plan for an effective and safe reopening.
Interesting. So now you've sort of moved from this, the idea of the convention center as a field hospital to acute care hospitals to primary care. Now you're really trying to get out into those non-healthcare entities that are out there to say, okay, how do you move forward safely, trying to decrease the risk for everyone as much as possible?
Exactly. Our first mission in public health and emergency response is to save lives. So that's why we really had a lot of focus in ensuring there was hospital capacity. We had enough ventilators. We focused a lot on PPEs for those acute care facilities, but we realized quickly thereafter, as this is becoming a disease within the community, we have to really rely on the help and assistance of our primary care providers as well. So now ensuring that they have the supplies and the equipment that they need, and then beyond that is into the community. So if you think about it, it's primary prevention, secondary prevention, and tertiary. Primary, and making sure that people don't get unnecessarily exposed in the community. Secondary, to make sure if they are exposed, we have the appropriate testing as soon as possible to identify them and to prevent further spread. And tertiary, of course, is new solutions. So we recently got an allotment, or actually multiple allotments of remdesivir provided to the state. So we're involved in working with the VHHA to distribute that across the healthcare system, and beginning to think about what are the other unintended consequences of this long-term disaster.
So let's look at that example. So remdesivir seems to work for hospitalized patients who are not too sick. People seem to want to get it earlier. It's only intravenous, so you need to be an inpatient to get it. If the VHHA or the VDH entity is thinking about dispersing doses across the state, how does that get decided? How much, say, big academic center like VCU gets versus, little tiny, rural community hospital? How does that work?
Sure. So I'll give you a little bit of a background of the system that we put in place in March and April, not knowing we would be dealing with this issue at the end of April or at the end of May. And so when we started this effort, and specifically thinking about providing care out into the community in areas where care may not be provided, again, the convention center being utilized as a field hospital, we actually stood up the Virginia Disaster Medical Advisory Committee. This is a group that basically helps inform the crisis standards of care planning. So thinking about, to an earlier question, is in terms of pandemic, we have been preparing for such an event should it ever occur. So we had a playbook. We had a draft playbook, which has significantly been revised in the real event. But we had a playbook in terms of how do we implement a crisis standards of care. And that would include representatives from the health department, VHHA, a legal partner from outside of a state institution, a medical ethicist. And we have talked about also, with the emphasis on vulnerable communities, of having representation from the health equity and policy group of the Unified Command. So those individuals came together and started thinking about what are the steps that we need to take to ensure that individuals can get care that they need based on the resources that we have. So we put that framework in. And once we realized we're not going to go to the field hospitals, we actually took a pause. But when the federal government said, hey, we have some remdesivir, that was the unit which we then activated once again to determine where these go. As you may recall, there was a decision by the White House Task Force and HHS initially with the very first allotments of remdesivir that was sent directly to individual hospitals that had a fairly high amount of morbidity and a high amount of disease in those systems. Here in Virginia, and the Inova Health Systems was the system that received some small direct shipments. And I think it was quickly realized at the federal level that really this would be a better function that could be coordinated by the state. States know the locality, know where the resources are. This is an IV medication that needs to be utilized under certain parameters. And again, with that quick realization, the state said, the Fed said, let us send this to the state. We got the allotment, and what we did through that committee is thought about, where do we send this? Do we send it to the large academic systems that have had experience with this through clinical trials? And the initial shipment was so small, it would only treat a couple dozen patients when we had over 1,400 individuals. And the more and more we thought about it, we thought the fairest way to do is to do a lottery system where every individual who's COVID positive in a system gets one ticket. So a hospital that has 190 COVID patients gets 190 tickets. Another smaller critical access hospital only has gets three tickets. And like you mentioned, there are certain parameters that dictate who is able to, what types of patients really would benefit from this medication the most. We didn't want to get into the weeds. We just simply had, at the state level, the number of COVID positive confirmed patients. And so what we did was, again, this random sample drawing where every hospital was provided a ticket per patient, and we were able to distribute as such. So we went from being able to distribute about 10 cases to 94 cases. That's in 3 weeks thereafter, the amount of remdesivir that we have received would be able to treat anywhere between 900 to 1,600 patients. And again, going back to your comment, those who are on vents, on ECMO, they're going to require 11 doses. Those who are not require 6 doses. So depending on how it's distributed within the hospital system would determine how many doses and how many individuals can be treated. And all we try to do to have some accountabilities, we ask every health system that receive remdesivir to let us know exactly how many cases they have on hand, the number of patients it was used for, and they had to attest to the fact that they would, similar to the state, have some sort of a committee that would go through a decision-making process of who gets that medication. And again, following principles of equity, principles, again, that many who work in this field are familiar with, so that we ensure fairness and equity across the board.
I appreciate that, because it does sound like it's a thoughtful process and strives to be fair. Let me, since we're getting near the end of time, and I want to make sure there's some time to look at a few questions, I want to ask about the future. So, there's the rosy picture of things are slowly getting better, and then there's the thought that case numbers are going up, even though we're testing more people, and they may be getting worse. So, how are you thinking about the future in terms of planning for what's next?
Sure. We're going to do all that we can, regardless of when the second peak comes, when it comes to increasing our testing capacity. Ensuring we have more PPEs on hand for our providers. Again, we know that the acute care facilities, long-term care facilities are seeing less shortages, but we realize that a lot of our community providers are still having difficulties getting PPE. So we're working with Amazon, just actually an effort done last week to work with them to help distribute to some of our smaller providers across the state. So we got to increase those capabilities regardless of when a second peak comes. But some of the things we're thinking in terms of the acute care is, we know that once we put a stay on elective surgeries per se, we were able to increase the capacity of the hospitals within a matter of a day or two. So we were down to 60% capacity in a lot of the states. So even if we see a potential increase with elective surgeries, procedures, or other sorts of needs within the acute care setting, we know that if we get near to the top, we can always potentially go back to that if necessary. Our hospitals are actively planning for that surge capacity. So they are required to have some plans to go beyond their normal day-to-day bed capacity. So those plans have also been thought about. This isn't going to catch us off guard. And I think certainly what's going to happen in terms of the policies that we see, how well people adhere to social distancing, and perhaps what other therapeutics come our way, is going to all really impact how we respond to the second wave. And the biggest question, of course, is the availability of vaccines. Will we have that in our hands before we see a resurgence?
So as healthcare practitioners, what should we be doing now to make sure that we are more prepared for whatever the future holds?
I think we all learned a lot of lessons with this disaster, looking at how each of us were impacted from a business standpoint, from a economy of operations standpoint. We've seen the operations change. A lot of providers go into telehealth, telemedicine services, trying to identify the gaps so far within the response, and trying to take those lessons and learning from it. I think looking to the future, again, getting information from the CDC website, the VDH website, webinars such as this, because this is such a fluid environment, the decisions that we're making at the state level seem to change week by week, because we want to be as responsive to the needs of the community. Probably the same thing for our clinical providers. We just talked about the use of remdesivir. There's likely to be more guidance, more information to come out once this is used in the general population. So keeping abreast of that is also very important. Last but not least, within the community level, and what we need providers to do is they make the connection to the patient. We have a public health role, but we aren't able to provide that one-on-one patient education, patient guidance, patient evaluation. So we need our providers to continue in that very, very important role. And when vaccines come around, to continue. I guarantee we'll have some of our skeptics who will worry about this new vaccine being safe, and we need our providers to continue providing that education when that vaccination is available, and really continue to work with us throughout the course of this response.
Yeah, it sounds like we still have a lot of work to do, and we're not near the end of this at all, certainly. So we've got a few questions here. So one of the questions was around public health dollars being cut. And I think it's probably referring to things like the pandemic response unit. Did those kind of decisions, did you feel direct effect of that at the VDH level?
You know, over the last several years, we have seen some changes with regards to the amount of support. We have, again, tried to make the best use of the dollars that we have had. You know, one can always argue with more money, you have more time to prepare, more time to educate, more time to train. And perhaps buy even more supplies. So I think the bottom line is more funding allows us to be more versatile and more flexible in our response. The discussions there, the conversations there is really at the federal level, but I do think those can have ripple effects in terms of if you don't have a clear strategy at the very, very top, perhaps those are the individuals that can provide the guidance, ring the alarm bells when there's something of a national emergency that would then again, have that ripple effect throughout the communities. But we're, again, doing the best that we can with the dollars that we have.
Great. And then there's a question about the Medical Reserve Corps. And I don't know how that fits into your office specifically, but how do you interact with the Medical Reserve Corps, and what expectations do you have for that group going forward?
Sure. So in my day-to-day job, I oversee the Office of Emergency Preparedness as well as some of our other regulatory functions. And the MRC is a subset of the Office of Emergency Preparedness. And VDH, we have 35 health districts led by medical health officials. And in each of them, they have Medical Reserve Corps that really work and respond under them. The state coordinator is with us. One of the biggest benefits, one of the silver linings of this response was certainly the governor putting out the call for individuals to sign up to the Medical Reserve Corps. And we have seen Virginians do exactly that. We have increased our capacity by the thousands. And so we brought on medical students, nursing students, professionals, retired professionals. Those were in the high risk category said, well, I may not be able to see patients, but what can I do on the back end? How can I help with contact tracing? What kind of patient education can I provide? And it's been really a remarkable resource that we're still continuing to augment, partly in response to a potential need if there's a second wave. So we have really seen that effort increase over the last few months and hope that it continues strong.
Great. So I don't know if you know off the top of the head, what's the easy way to sign up for the Medical Reserve Corps?
Probably the best way is to send you the link with regards to, if you Google VDH MRC, I think that's the easiest way to come about it. What will happen is that individuals will, again, get signed up through their local health departments, local health districts. So a call to your local health department would be another way. Individuals get their credentials checked, a background check, and then they get on to helping with the mission.
Great. All right. We'll make sure that that's linked. Parm, thank you for joining us.
Thank you for having me.
Great. And I want to thank Canvas for letting me record here, and Terry and the CE team for help putting this on. As a reminder, you can get free wills and advanced directives through the Medical Legal Partnership. If you're a healthcare practitioner, they're offering this for free through, I believe, the end of this week. To contact them, email mlp@vcuhealth.org. And they're happy to work with you to put in touch with lawyers who are donating this service to healthcare providers because of the work that we're doing. And our silver lining today, I think I'd be remiss if we didn't mention some of the challenging times that have happened over the past few days with the killing of George Floyd and Ahmaud Arbery and Breonna Taylor. And I think it's really brought out some of the inequities that are in our system, both in terms of policing and violence, but also as well as our health equity. And so these are trying times for all of us with both the pandemic and the protests going on. But I think it helps us think about the health inequities in our system and the damages that we've seen to communities with COVID, as well as with some of the other things that are going on. So I think there's a silver lining in there that maybe we'll arise from this stronger and better together, but we got a lot of work to do. So hopefully that's a silver lining. With that, hope you're all safe. Take care.